Pleasure and honor to introduce today's speakers in the Distinguished Speaker Series of the Health Equity Research Theme Seminar, because I've had a chance to collaborate with them and seen them in action doing their remarkable on-site work among some of the most structurally vulnerable populations in the northern borderlands of Mexico, and I'm inspired by them. And just as an aside, it's a population, a large proportion of that population comes from LA because of our mass incarceration, deportation, zero tolerance policies, but they'll talk about that in some detail. We only have 50 minutes, so I'll try to be brief. Dr. Alhelí Calderón-Villarreal is a primary care doctor and global health social medicine researcher who has been a community-based private has had a community-based private practice in Tijuana since 2018 and is currently about to complete her final year of the global health track of the UC San Diego School of Public Health. She was born and raised in Torreón, Mexico, a provincial town in the border state of Coahuila, where she received her BA at the state's National Autonomous University and an MA from the Mexican National Institute of Public Health. Her scholarship is on the front lines of care and policy reform advocacy for environmental justice and improving infrastructure, health and social services and civil rights in the Mexican borderlands, the borderlands to the north with the US for the underserved in Mexico, focusing especially on the structural forces devastating undocumented migrants. There's a large population that becomes trapped at the border, which is a transshipment point for cartel narcotics entering the US, and fall into injecting drugs without access to stable shelter, potable water, personal security, and civil rights. And as she shows, the specific vulnerabilities faced by women in these environments is particularly underserved, and she offers concrete infrastructural suggestions for remediation. Her work is courageous and methodologically innovative, mixed methods combining epidemiological survey, toxicology, laboratory testing, qualitative observation interviews, and also includes hardcore participant observation, anthro-style data collection in one of the most violent regions of one of the most violent countries in the world right now, first because of its location as the southern neighbor of the United States. Theoretically, she is advancing the field of global environmental justice in the tradition of the 1800s origin of the field of social medicine and epidemiology and public health and urban planning of scholars like Rudolf Virchow, the inspiring progressive doctor dedicated to eradicating cholera among the poor with that great quote, "We will count the dead and see where they lie thicker." Oops. Among the rich or the poor. I always tell that to anthropologists who don't understand quantitative methods. You do have to count people. You can't just talk about them. Dr. Calderon is also a leader for young women in global health as the co-director of the Mexican chapter of Women in Global Health, which is bringing women's health into the center of the field. Just since 2020, she has published 11 peer-review articles in leading journals, ranging from the American Journal of Public Health, the Lancet, PLOS One, all the way to social science and medicine in the social sciences. And now, more quickly, I will do a shorter shrift to Joseph Friedman, sorry, Joe, who received an MPH in Global Health Metrics and Evaluation in 2017 at the University of Washington and a PhD in Social Medicine, Medical Informatics, and Ethnographic Methods at UCLA in the Center for Social Medicine in the Department of Psychiatry, where I'm located. He is also a Geffen Scholar. His work is at the cutting edge of harm reduction, melding population health analysis with anthropologically informed participant observation methods to reconceptualize and instrumentalize on behalf of the underserved public health surveillance. And he's addressing the populations most brutalized by society, that is the unhoused, the consumers of methamphetamine and opiates in this setting. He's also finishing his third year as a medical student here at UCLA. He started publishing already as a master's student in 2016 and is mind-bogglingly prolific, intimidating for a 66-year-old like me, with 46 peer-reviewed publications, more of half of them as first author in many of the highest impact journals in medicine and public health and the medical social sciences, from Nature, The Lancet, JAMA, American Journal of Public Health, and PLOS One to the International Journal of Drug Policy and Social Science and Medicine. So thank you both for coming and for the inspiring work you do. And thank you also to the faculty of family medicine in the medical school and the International Institute's Global Health minor on our North Campus for also being present or for consulting this HEPS event online or being in the remote audience, which had a lot of registrants today. Okay, Alhelí, the microphone is yours, and forgive me for taking up so much of your sparse time. So don't hesitate to put questions in the chat, especially those of you that might need to leave after an hour. Okay, thank you.
Thank you very much, Philip. Thank you also for the invitation. We are going to talk about the structural violence on the US-Mexico border, intersecting forced migration, overdose, water, and human rights crisis. We will be talking about some of the projects that Philip just mentioned in the introduction, and you can keep the questions for the end of the presentation. I think it's not working. Okay, this talk discusses distressing themes such as sex trafficking, drug-related deaths, and police violence. We also will be showing these kind of QR codes during the entire presentation in case you find something interesting during the presentation that you want to check in the internet, like this could be figures, videos, and different sources. So keep in mind to have your phone, you can open the camera and check the QRs. In this case, you can see some of our publications and stuff in these QRs. But before we continue, we will talk a little bit about who we are, because that's important when we talk about qualitative research and social science research. The positionality of the researcher is very important in the way we look at the problematics. So as we briefly, that Philip briefly mentioned before, I'm a primary care physician from Mexico. I'm from the north of Mexico. When I was 10 years old, I moved to Tijuana, and then I came back for med school in my hometown, Torreon. I have a master's degree on public health with a focus on social and behavioral sciences. I also have a special training in global health and also in mental health among migrant populations. My interests include social determinant of health, health equity. I'm also very interested in the access of human rights and basic services among underserved populations. This includes refugees, deportees, unhoused people, and people who enjoy drugs, especially in the US-Mexico border. I have experience working in different regions and countries, collaborating with organizations in Latin America, in Europe, Asia, Africa, different areas. But for this talk, we will be focusing on our experience in the US-Mexico border. I'm also the founder and the director of a project called the Social Environmental Tijuana River Project, that actually some of the co-authors are here. And we will give you more information about this project, which is a central part of this presentation. Now I will be giving the microphone to my colleague.
Hey everyone, I'm Joe. I think Philippe did Philippe, who's a dear mentor of mine, did a great job of introducing me already. I'll just say that I just finished my PhD this year here at UCLA in the Center for Social Medicine, and I had the privilege of spending most of the time during my PhD down on the border with Alhelí, working on this project she's going to talk about. And it's really been one of the best parts of my training here at UCLA. And I'm so grateful for the opportunity to present this work today to you. Thank you.
Thank you. I think I didn't mention that I'm a PhD candidate in the University of California, San Diego, and San Diego State University. Okay. Oh, this is a talk outline. We will be talking about the concept of structural violence. And after that, we will give you some examples about how forced migration, overdose, water, and water are interconnected with the structural violence at the border. After that, we will give you a conclusion. And after the conclusion, we will talk a little bit about what's next. Well, structural violence is a framework that describes how social structures and political and economic forces drive systematic harm through mechanisms of economic, political, legal, and social oppression. In other words, we know that statistically, some people are in disadvantage, having lower quality of life, die in a younger age, and also have worse health outcomes. So structural violence gives us the opportunity, gives us the language to talk about these systems that create social and environmental injustice and also health inequalities. Forced migration, it's a vector of structural violence. As humans, we have the right to migrate looking for opportunities. According to the UN Agency for Refugees, we know that there are more than 100 million people that migrate all over the world from different reasons, including violence, climate change, and poverty. Just in the US, we know that more than 43 million immigrants live in the country, and more than 3 million of them only in LA County. But all kind of migration is important. But in this specific presentation, we will be talking about a very specific kind of forced migration, the deported population. A lot of these 43 million immigrants in the US are vulnerable to be deported in very diverse type of circumstances. Deportation rates have been the same in the last decades. Since the 90s, the annual deportation rate increased 13 times. Now we have 400,000 deported people every year, more than half of them without criminal records, most of them Spanish speakers, mainly from Mexico. Last year, the US deported more than 240,000 people into Mexico, about 40% of them to one single city, Tijuana, the city where I grew up. It's important to note that this quantity of people, this almost 90,000 people, is way far the quantity of people that arrive to Tijuana every year with migrant caravans, but taking far less attention. So, talking about the deporting population, specifically the ones that arrive into Tijuana, we are talking about double discrimination. That means that they were discriminated against in the US because they were migrants, and also for their nationality, their skin color, their ethnicity, different factors. Many of them migrate in a young age. They didn't decide to migrate. They could grow up in urban poverty, in segregated areas with gangs, being exposed to substance use in a young age. After deportation, they were separated from their families, their homes, their belongings, their children, and they became de facto stateless because many of them don't have papers in Mexico, they don't have Mexican ID, they don't know the environment, they lost any social and family networks, and many of them don't speak Spanish, which makes them very difficult, very challenging to adaptate in the new environment. Also, we know that with this double discrimination, we know that the deported population in Mexico are target of a lot of discrimination, police victimization, social isolation, and other type of discrimination. Okay, but what happened after they arrived to Tijuana? Of course, there are many that has a lot of opportunities and come back with a good quality of life, but we are talking about a very specific type. These are the people who grew up in the US since a very young age. So we are talking about migrant children. They were deported into Tijuana, and many of them found refuge in the Tijuana River. The Tijuana River is a binational river, and it's the home of the largest unhoused community in the city. Most of these communities are people who enjoy drugs, who were deported from the US. Every story is different. This is only one example of them. This is a quote from Javier, a 59-year-old man from Ciudad Juárez, Mexico, who was deported from California and who have been living in the Tijuana River for the past 6 months. It's already been 2 years since I was deported. They just left me here to grow old, and there is nothing I can do. I swear, honestly speaking, I had never led a life like this. When I was in California, I never thought it could came into this. I mean, I came from a good family, we weren't poor, we were middle class, business, cars, we weren't missing a thing. But I got caught with drugs, and lost my green card, got deported, lost everything. Most of my siblings are US citizens and everything. We will be sharing different stories to construct this talk. Now I'm going to pass the microphone to Joe to talk a little bit about this part of substance use and overdose that is connected with this forced migration type of history.
Thank you. Okay, so on the topic of addiction and overdose in Tijuana, first I want to share a little bit about the ethnographic approach that we use to understanding the structural problems that we're going to be discussing today. So ethnography is longitudinal participant observation research that is qualitative in nature, right? So in this case, what it really meant was accompanying people who use drugs in their daily activities as they look for money, generate funds, try and find housing, use drugs, talk about drugs, have arguments, everything that people do in their daily lives. And with their consent, their active consent and IRB approval, you informally interview them, you take out your phone and do a little interview about some topic that they know you're interested in, and it's for your project, for your book, for your article. And there's lots of videos and photos and audio recordings, and as well as detailed field notes that you take during the field work and after the field work. And all of this rich qualitative data goes into a database and is coded qualitatively for the content and the themes. Here are some snapshots and photos which you could kind of imagine represent these micro little moments out of this vast kind of database of ethnographic data, which we then spent a lot of time analyzing to come up with these analyses. And a part of my dissertation here at UCLA was arguing that ethnography should really be viewed as a public health tool, because it allows for access to, quote, common sense realities that are often very elusive to quantitative research. So things that are just obvious if you're there with the population, but if you're kind of coming up with a survey or a statistical analysis might not be obvious if you're not on the ground. And we have some articles here, which you can download with this QR code, where I think we are able to show that ethnography is very effective for understanding rapidly shifting and clandestine things like illicit drug markets and risky practices. And in these papers, what we've tried to do is generate hypotheses using ethnography, where we say, we've noticed this is true for this small sample size of people. And then we can quantitatively test, is this true, for the country or for these kind of wider environments? And this is the model that we're trying to use. So I'm going to be explaining some trajectories. The names here are obviously pseudonyms. Many of the details that are unimportant to the main points have been changed, okay? But so this is the life of Ricardo. He was raised in the US from age 1, although he was born in Mexico, and he was brought by a single mother who went to the US to escape domestic violence. So she was in the US, though she had a hard life and she had to work 2 or 3 jobs to make ends meet. So Ricardo was often home alone in a rough urban Southern California neighborhood. Gangs and retail drug markets were on his front steps. So from a young age of 10, he was pulled into the retail drug market, doing things like holding the drugs when the cops came because no one's going to search a 10-year-old, running errands, things like this. These were just his friends. This was all he knew. This was his life. This exposed him to illicit substances from a young age. From early adolescence, he struggled with substance use disorder, but his drug use waxed and waned. So it would become more and less chaotic. And during periods of relative stability, he had various very successful jobs. He was married. He had 3 kids. And unfortunately, he was arrested for drug possession and lost his green card in his late 40s. And he was deported to Tijuana. He was separated from his wife and his 3 children. Initially, he actually landed on his feet. He wasn't using chaotically. He had a job, he had an apartment, but unfortunately, as he grew more distant from his wife, they became separated. He became depressed, began using heroin chaotically on a daily basis, and became homeless, where I met him in a harm reduction environment and proceeded to spend a lot of time with him, and noticed him starting to kind of overdose numerous times related to his, as he began to use this new heroin product that everybody called China White, instead of using black tar heroin, he started to overdose in this kind of cyclic fashion and be revived when Narcan was available, thankfully. And now we'll talk about Mary. So Mary was actually orphaned as a young girl in the US. She was raised by a friend of her mother. And like many children who were in and out of the foster care system, she was very vulnerable to sexual exploitation. And she was actually basically forced into initial heroin dependence by a sex trafficker, which is unfortunately a very common practice, where she was kind of rendered dependent to heroin against her will. And then she escaped that situation and she reestablished a new life. But at age 8, as a young adolescent, but at age 18, she learned she was undocumented because she went to the DMV and tried to file paperwork and realized she had no legal identity in the United States. She was using heroin her whole life. In her late 20s, her boyfriend and her are arrested for heroin possession and distribution. Like many people who use heroin their whole lives, they ultimately ended up resorting to selling some heroin to people they knew to generate funds to buy the heroin, and that got her deported to Tijuana. I meet her on the street in Tijuana. She doesn't speak Spanish. Everyone says you don't look Mexican because she looks African-American, and that's how she's interpreted broadly, but of course she doesn't have the papers of someone in that situation. And she's just surviving day to day on the street, where we meet her as a team, as an ethnographic team, as part of the project that Alhelí led in the river canal where she was living. Here you can see a photo where she's engaged in an unfortunately common but very high-risk practice, because as peripheral veins become difficult to access, many people resort to shooting heroin directly into their jugular veins because it's just the good access point that is still available. And she also began to overdose frequently and it was directly correlated in her case to other people overdosing around her. And what we would see ethnographically is that as the potency of China White, whatever that was, would seem to increase, and a bunch of people would overdose, and then something would shift and nobody would overdose the next week. And it was kind of this wave of clusters of overdoses. So now I want to make the case to you and kind of highlight some commonalities between these 2 cases and these dozens and dozens of other cases that we didn't have time to talk about today, to make the argument that overdose in Mexico is really a deported and exported phenomenon from the United States. So it's important to note that although cartels in Mexico actually produce and export massive amounts of heroin and now fentanyl to the US, addiction rates in Mexico are very, very low compared to the United States. The injection drug use that Mexico does have is heavily concentrated on the border with the US, especially Tijuana. And the majority of injection drug users are actually US citizens or residents or deportees who had injected heroin in the US before deportation. In other studies among people living in Mexico broadly, having lived in the US is the strongest risk factor for having a substance use disorder in Mexico. And that's because overdose is a uniquely US problem. Here you can see a graph showing on the y-axis the per capita overdose death rate. And I'm sorry, this is a little blown out, but you can see the line for the United States here is 20 times the global average, 2 to 3 times higher than the second most affected country, 10 times higher than, the top 10 countries. This is an extreme problem. We're this extreme global outlier, right? And many people have theorized that this is because something about US society actually creates addiction and mental illness. If you look on the right here, you can see the prevalence of common psychiatric conditions in the US in red and Mexico in blue. So for example, you can see that the US has 6% of all people have a substance use disorder compared to 2% of people in Mexico. There's a 20-fold gap for opioid use disorder and a gap as well for anxiety and depression. So the theory here is that exposure to our society, to US society, is kind of this key risk factor driving the risk of overdose in both the US and Mexico. Now, quickly, I'll just talk a little bit about why this shift in the drug market matters. So here's a sample of China white powder heroin. It's a white powder. Here's an example of black tar or goma negra heroin. And in some ethnographic data that I'm going to blow through pretty fast, unfortunately, just for time, basically ethnographic participants told us that this new form of powder heroin was much more likely to cause overdoses, much more euphoric, much more potent. And importantly, we actually have some insights into the nature of the illicit drug market because this participant, Guillermo, who's a 30-year-old male who actually injects and sells opioids, as does the vast majority of people who sell opioids, he tells us that the batches of powder heroin and fentanyl are mixed together in like a bowl, a kitchen bowl, and those batches will last one corner sales points 3 or 4 days. So depending on the middle school educated person who is mixing, not that matters, but the person who's mixing this up has no formal training in chemistry or in working with substances. There's no regulation. These are very potent. Fentanyl is potentially 40 to hundreds of times more potent than heroin. So depending on the potency of this batch, we would see ethnographically this huge number of overdoses occur or not. And we were actually able to correlate this ethnographic information with drug checking data. So here you can see we did mobile harm reduction syringe exchanges all over the city. We were able to test syringes and we were able to map out the prevalence of fentanyl positivity in syringes at these different points through the city. And the main result is that in sales points where only black tar heroin is sold, we see almost no fentanyl in syringes using kind of chemical data. And in places where China white is sold, we see a bunch of fentanyl positivity. So it's just kind of this confirming statistically and chemically this obvious fact for anybody who lives on the street. And on this topic of statistics, unfortunately, although we know that overdoses are definitely going up in Mexico, we don't know by how much because most overdose deaths in Mexico go unrecorded because there is not good toxicology and autopsy infrastructure. So here is the official numbers, the official number of opioid overdose deaths in Mexico per year compared to 100,000 in the past year in the US. Or 107,000, and you can see the number ranges from 3 to 16. And every expert that we have talked to thinks that this is an absurdly low number. If you compare this to this bag of empty Narcan vials that was collected at one harm reduction clinic on one street in a very short period of time, these were all used to save a life, right? And many, many times this is not available. So we know that there's this huge wave of overdose deaths that's simply not being measured. So in conclusion, the case I'm hoping to make today is that ethnographic information tells us that there is an overdose death crisis in Mexico of unknown but rising magnitude. These deaths represent the end of trajectories that start in the US, but are deported and exported to Mexico. And this can be conceptualized, we argue, as the deported segment of the US kind of homegrown overdose crisis. This segment is invisible in that it does not show up in any formal statistics or formal death registry. And the implication is that, one implication is that without deportation, US overdose death rates would be higher. So I would argue this represents the intersection of US drug policy and immigration policy in action. Finally, although we've been mostly talking about the US, I want to mention that there is a great need for investment in the public health response in Mexico, where Narcan remains scarce. Part of that is because it was classified as a controlled substance until just a few months ago, which makes it difficult to kind of transport and access. Methadone and buprenorphine are also difficult to obtain and more costly than simply continuing to use fentanyl in many cases. And there is constant police violence and short-term 36-hour rounds of incarceration that destabilize people, where they lose all of their possessions, they lose their money, they lose their identification, their medications, including for things like HIV and Hep C. And they're just basically taken just by themselves to prison, to jail, held for 36 hours, and then released in this never-ending cycle of police victimization. So now Alhelí is going to be talking about some of the other kind of basic unmet needs that make it hard to find stability and move on in life.
Thank you. Well, now we are going to connect the first two topics, the forced migration with the overdose, with another important areas for human rights. We are talking about water, sanitation, and hygiene access. We simplified it as water, but these three things should be together most of the time. Access to water, sanitation, and hygiene services is considered a human right, and it's also considered the most crucial major urban environmental infrastructure necessary for human survival. It's also a core concern for public health, epidemiology, and policy-relevant disciplines. However, vulnerable populations in different contexts have still, in 2023, insecurity accessing those services. In this case, we will be talking about this population, that a big proportion of them live inside this binational river. Also, specifically, the people who inject drugs have a very particular water needs. They need water to prepare drugs for injection, and they also need water to clean wounds and abscesses. Wounds and abscesses, specifically abscesses, are very common among people who inject drugs in any context. It's estimated that about half of the people who inject drugs will develop abscesses at least once. This is one of the most important hospitalization reasons for these people, and it's also a very common way to have chronic pain and also to limit mobility, depending on where the abscess is. I will stop a little bit to talk about this project because I will go into some of the results with more details. The Socio-Environmental Tijuana River Project, actually, this guy is in the audience right now. This is a binational transdisciplinary group that is composed for activists and academic. In this group, we try to put together the academic part with institutions from US and Mexico. We start with colleagues and students, professors and students from Pomona College, UCLA, UCSD, UC Berkeley, and from Mexico, also from the State University of Baja California, and later with El Colegio de la Frontera Norte, which is the most important research institute in Mexico that work on migration. We aim to simultaneously characterize the Tijuana River water quality, the water, with the people, studying the health risk of the Tijuana River inhabitants. So this is why we are talking about a socio-environmental perspective, because we want to have an ecosystemic and human rights perspective of this specific area, because in Tijuana, when we talk about the river, when we talk about the water, it's usually focused on the environment. And when we talk about the population, we talk about substance use, HIV, but never connect. So what we have in common, I mean, Joe and I, the way we usually try is to use mixed method to connect, to work in transdisciplinary teams, so we can see the big picture of whatever we are studying. So we mix biochemical testing of the Tijuana River water quality. We also use participant observation. We mix ethnography with semi-structural interviews and also quantitative survey. We explore the socio-demographic characteristic of the population. We check like general health outcomes, how much they use and contact the Tijuana River water, among other interesting indicators. Well, but what is this river about? This is a binational river because cross the border multiple times is regulated by the International Water Agreement between Mexico and the US. The river watershed is at both sides of the border. And after crossing the border multiple times, cross the Tijuana city, as you can see in this map, it crossed the city, including the industrial zone, which is a very important thing to mention. I will talk about more. I will talk a little bit about more of this later. Finally, cross the border again into the Tijuana River estuary to finally reach the Pacific Ocean. So water pollution in this river is intrinsically connected and shared by both nations and affect human, animal, and environmental health. Of course, we found that the Tijuana River water was contaminated with bacteria and with other indicators that shows bacteria growing. We found that it's contaminated with sewage and industrial and agricultural discharges. E. coli values were about 40,000 times the Mexican regulatory standard for direct contacted water. And in general, with the rest of the indicators, contamination levels exceed Mexican and the US Environmental Protection Agency water quality standards, which represent an acute health risk for the population who contact this water in their daily life. It's important to mention that we study the river in this area, but specifically based in ethnographic data, we study the water quality next to where the people live. So we want to know exactly the water closer to them. Okay, now talking more details about this population, we are talking about mainly young men, Mexicans by birth, unemployed or with informal jobs. They have reside in the US and were deported. Most of them inject heroin or methamphetamine. And because they are in a housing insecurity situation, they have limited access to basic services and human rights. They are often victims of police violence. Many of them don't have any kind of documents or identifications, limiting their capacity to work. And HIV, hepatitis C, and tuberculosis rates are very high among this community. The population living in the Tijuana River know the water is contaminated and then try to avoid it. They develop a very detailed taxonomy of water sources to know which water sources they can use in which situation, including the river itself, but also like gas stations, convenience stores, and other public water funds. They have lack of access to different services. As you can see in this picture, there is a guy, he's cleaning some clothes. You can see that they can use this stuff to do laundry. And it's important to mention that because of the lack of access to water, sanitation, and hygiene services, these people are forced to use the Tijuana River water, but also because of police hunting, police persecution, they are forced to cross the river and be in contact with the water, and they recognize this police right as the main reason they are in touch with the Tijuana River water. So this is how we connect, how police violence is affecting directly their contact with the highly contaminated water. Now I will read you a quote from Max, a 38-year-old man originally from Guerrero, who worked cleaning cars and was supported also from the US. When they let me in, I wash clothes at the gas station when I go into the restroom. Sometimes they let me do it because I clean the restroom for them. That's how I pay to use the bathroom. I have to clean it, but at least I get to wash my stuff. Plus, I can sometimes fill up a bucket with water from the tap and bring it back here with me. Lack of hygiene in almost any context exacerbates social exclusion, discrimination, police victimization, and loss of dignity and self-esteem. These are the results for the water-related condition we study among this population. We can see that on the x-axis, you can see different water conditions studied in this population, and on the y-axis, you can see the percent of people that reported one of those in the previous week. Almost half of them reported having a skin infection or abscesses, which were associated with river water use or contact in the previous week. The second most common water-related condition was dehydration, which is really connected with the lack of water sources, and followed by diarrhea, and you can see other type of infectious disease that are related with the contact with contaminated water. A part of the water-related conditions, we found that there is a high proportion of people with disabilities caused by diseases, but mainly by violence and accidents. These include being hit by a car, fall, being beaten by a police officer, and also many of these cases end in untreated wounds, in amputations, and also in broken bones. As you can see in this picture, these kind of accidents and violence are very common with a very low access to healthcare services in the city. Also because of the discrimination, even if they arrive to the hospital maybe don't even let them in, or maybe they go in the hospital, and because in the Mexican public health system, it's not common the use of opioids. So it's difficult that they have the support. People who use drugs need to be in the hospital, so they prefer to leave the hospital with that untreated broken bone instead to stay with the malilla, with the syndrome for not using opioids. Okay, so we developed this diagram to exemplify how structural violence is connected with the environment. There is a concept of environmental injustice. That means when populations are deprived of clean air and water necessary to perform daily life activities, such as eating, sleeping, and working in disproportionate fashion, forces socially, politically, and economically marginalized groups. In other words, how the worst part of the environment is affecting the most vulnerable populations. On the other hand, we know that structural violence is very broadly helpful for understanding the social, economic, and political forces driving high rates of morbidity and mortality for this population. So in this case, we can see how structural violence is causing poor health outcomes in this population, but also how structural violence through the environmental injustice is also exacerbating these poor health outcomes. So the environmental structural violence framework highlights the role of environmental injustice, including contamination and control of space, as a unique nucleus by which structural violence works. Additionally, as I mentioned before, that the river crossed the city very near to the industrial zone. We found that fecal indicator bacteria levels increased since the early years of the North American Free Trade Agreement. Well, not only we found this, there are more research groups that state this information. They state that it's a symptom of this deep economic inequality between the global North and South. After this agreement, Tijuana became as one of the major manufacturing hubs for the US corporations. Maybe you don't know it, but a huge fraction of the medical, electronic, automobile goods consumed in the US are made in Tijuana. That creates a wage disparity at the border, open for capital, but closed for laborers. Let's keep in mind that we are talking about the most crossed border worldwide and an iconic border that separates the global North with the global South. Tijuana has one of the fastest growth rates in the country, growing more than 7 acres per day. This is caused by a massive migration waves from different parts of Mexico looking for opportunities, but also from people from other countries, including people that arrived to Tijuana as a safe third country, waiting for asylum into the US. That includes also refugees and internally displaced from other parts of Mexico and people in general from other countries and regions. This massive growing of the city challenges the city capacity to invest and develop infrastructure, which include this wastewater system, an effective wastewater system. For half of a century, many of these factories have routinely discharged pollutants and untreated or minimally treated sewage into the river, escaping legal consequences. You can see the references. I'm not the one saying that. In combination with tax exemptions, subsidies to corporations weaken the capacity for environmental protection regulations, partially privatize wastewater management, and drive underinvestment in wastewater systems and infrastructure. So, in conclusion, structural violence is occurring on the US-Mexico border and involves the intersection of many human rights issues, including water, migration, substance use, and of course, this is a very complex situation. We don't want to simplify the problem. Actually, the opposite. We want to have the big picture with all the complexity network that is around, how all these elements and harming and giving and affecting the quality of life of this specific population. But as I told you before, what's next? I want to thank these two local organizations, Preven Casa and Proyecto Fronterizo de Educación Ambiental. Prevencasa is a local harm reduction clinic. They provide services to people who use drugs, to no-house population, to refugees, to deportees, and they provide a mobile clinic into the Tijuana River Canal, where we join and collaborate to do this project. And Proyecto Fronterizo is an environmental education NGO. They have water quality lab, and they advocate a lot for the river and for a bunch of other environmental problems at the border. This is the list of co-authors. We also want to thank the students, volunteers, and the academics, and all the people that collaborate in this project. After we present the first results of this project, we came back with some hygiene kits, and we present the results to the community. I mean, the community first. And now we are planning on the dissemination to stakeholders and general public. So you are all invited to attend the official presentation on February 23rd in El Colegio La Frontera Norte. We will have transmission by YouTube and Facebook Live. We will present the results to stakeholders from Tijuana and San Diego, from both sides of the border. And after that, we will have a panel of experts, so people from San Diego and Tijuana, from civil society and academia, will discuss and comment the implication of this project. And after that, we will have a workshop, a theory of change workshop, in a closed room with key stakeholders of Tijuana and San Diego to develop the first draft of a socio-environmental set of solutions for the problematic in the Tijuana River and its population. So this kind of ambitious, but we need to start somewhere. We also have some publications from the second phase that we want to share later, some of them on police violence, other on territorial fragmentation, other on disabilities, and many other topics, because it's a very complex problematic. And also, if you want to see, we have a special report in Telemundo San Diego from when we start the project. You can see it with this QR. And that's it. Thank you very much.
Great, that was fantastic. We have five formal minutes left for questions, and I clumsily didn't look at whether people put them in the, let's see, Q&A here. Okay, but if anyone wants to start, let me just see here. What I did want to just perhaps start off with. Oh, is that? Oh no. Okay, great. I didn't. Sorry, I got. Oh, you got a microphone. Yeah. Good. Thanks.
My question is sort of about recent policy. I doubt you would have had time to get into the presentation, but with the expiration of the public health emergency declaration and then presumed expiration of Title 42, the asylum refusal, do you anticipate or have you seen a change in the movement around the city of Tijuana? And do you think that'll impact especially the overdose deaths?
Yeah, that's a really good question. And I just want to say that there's some great people doing really good work directly with migrant communities. And we have kind of indirectly done a lot of work with migrants, but really it hasn't necessarily been the focus. So I don't want to, pretend to be like the best expert. Neither of us is probably the best person to answer that. I think, the reality on the ground is often so disconnected from what it looks like if you're reading the news. And so one thing we have seen, because a lot of times there's a free clinic, there's harm reduction there's free medical care, and there's free legal advice. It kind of comes and goes. And even when we were accepting asylum cases, there's like this random journal, there's a list, someone has it, it's on paper, you have to get on the list, it's very confusing. You know, that even when the border is formally open for asylum cases, it's de facto not open for asylum cases. And so all I would say is that I think that there's a lot of like political jockeying about these kind of what the formal legal, obviously international law is very clear. We just need to be accepting asylum cases. That's just the law, right? But in practice, that's not what we're doing. And I think, everything that's happened with the CDC and other, I think like the backlog has increased. There've been, some people are still getting through. It's all very confusing to us on the ground. And if you want to chat after the talk, I'd be happy to connect you with the experts who could give you like the best answer on that.
Hello, is it okay? Cool. You guys mentioned how like folks who have sort of like experience like traumatic like physical injuries won't stay in the hospital because of issues related to like withdrawal. Are there any efforts that you're aware of like educating physicians or healthcare practitioners in like the Mexican public health system to use? And I know earlier you also mentioned that it's harder to get things like methadone or other like medication assisted treatments for like opioid use disorder, but are there any efforts to like increase education or awareness of like Mexican physicians to like allow for better management of withdrawal symptoms?
Yeah, thank you for the question. Actually, the answer is Prevencasa. Prevencasa, this local NGO, they teach medical students in the city, but the challenge here is that the Mexican health system, well, it's fragmented, but it has like big areas. The part of the health system that work with this community is like the Ministry of Health, which is now INSABI. INSABI is the part of the health system with less infrastructure or less sources in general. So the coverage is a little bit less than what we have in other health system focusing on official workers, official employers. Okay, so the access to specific medicines is usually a national policy. This national policy works for the entire country, and Tijuana has a very unique problematic. So the local clinics have to deal with national policies at the same time when the reality is different. That doesn't mean that they could not have access to this medicine, but it's not common, it's not easy to access. In general, well, you could understand that Mexico is kind of afraid to use opioids for obvious reason that we can see in what's happening in other countries. So in general, Mexican physicians don't really want to go into this kind of practice. I mean, this is probably a cultural thing. I don't think that's completely fair for the patients because sometimes it's necessary. And what this local NGO does is that they advocate directly to the hospitals, and sometimes they provide the medicine to keep the patient inside. But many of these efforts are out of pocket from their volunteers. So it's money that people like any of you could be doing by yourself for a very specific person in a very critical moment. And well, I don't know if that answered your question. In general, Prevencasa is the one who is always in the front lines, trying to advocate with local government and with the health system about this kind of problematics.
Take one from the Q&A. So this is more of a technical question from the Q&A, but I think it's a fair question, which is how much of the discrepancy in psychiatric disorder rates between the US and Mexico do you believe to be attributable to higher rates of diagnosis in general? And I think it's a fair question that there's survey. So the estimates that I drew from to make that graph all come from surveys. And we know that like household surveys and phone surveys, which are done in the US and in Mexico are flawed. So if we think that there's some reason that they're systematically more flawed in one country versus the other, which I don't necessarily, I think we have kind of poor quality estimates of substance use disorders, but if just epidemiologically, it is like astoundingly clear that for substance use disorder, it is definitively much more common in the US than in Mexico. I think if you want to talk about anxiety and depression, like there's a little bit more uncertainty because of the data, but I think but there's enough robust study over time in cohort studies and in various other ways that we can say that unfortunately, living in the US probably increases your risk for anxiety and depression compared to having been born and growing up in Mexico.
Well, thank you for reassuring us that we live in a wretched country. And it really is a tragedy. It was very powerful material, beautiful photographs that really conveyed your methods and the site and made us understand it better. So thank you very much. And anyone that wants to come up afterwards is welcome to come up. Oh, I'm sorry.
It's something extra, not part of the presentation, but I want to thank Brendan, who is over there. And Brendan, when he was an undergrad student, he contacted us because he wanted to connect social justice with chemistry. And actually, this is how this project started. So thank you, Brendan.